Hello, I'm going to be discussing what's new with PrEP and HIV today. This is the faculty for our presentation. I'm Ethel Weld. I'm an assistant professor of medicine, pharmacology, and molecular sciences at Johns Hopkins. And Jim and Cindy will introduce themselves and follow my presentation. I have no disclosures.
So this program is provided by the North American Center for Continuing Medical Education, an HMP company, and DKB Med, and is supported by an educational grant from Gilead Sciences and Mylan. If you have any questions during the presentation, type it into the chat box on the lower left side of your screen under the faculty headshots, and the faculty will answer all questions at the end of the presentation.
The educational objectives of this presentation are to describe benefits of pre-exposure prophylaxis against HIV, determine who is eligible for PrEP, and discuss any barriers to initiating PrEP and keeping people on PrEP, assess factors that can complicate treatment, both treatment of HIV and prevention of HIV with PrEP in special populations, discuss the value of various treatment interventions that can improve adherence, and discuss some cost considerations, and to discuss the benefits of rapid initiation of ART. Here are my definition slides, so you can refer back to these at any point. Just wanted to start out initially by discussing some background on HIV in the United States. So incidence of HIV in the U.S. has slightly declined over the past 10 years. There's about 38,000 new cases. About 2/3 have a mode of transmission that's via male-to-male sexual contact, with heterosexual contact coming in second at about 16%. The graphic at the lower right shows the distribution of new cases of HIV divided by age group, and you can see that the highest age group is young adults from 26 to 34 years of age, but in second place is young children and adolescents in this age group of 13 to 24 years of age. It's important to note also that among the over 1 million people in the U.S. living with HIV, so this is prevalence, not incidence, greater than half of them are over age 50, as shown by this middle graphic. The majority, 3/4, are male, and people of color are disproportionately represented among those living with HIV in comparison to their percentage of the population. Here are displayed the U.S. Preventative Services Task Force guidelines for screening for HIV. These were updated last year. And there's a grade A recommendation to screen all adolescents and adults aged 15 to 65 years of age for HIV. People outside of that age range who are at increased risk based on appropriate screening questions should also be screened. Universal testing for all pregnant women, regardless of any circumstance, including those who present in labor or at delivery whose HIV status is not known. And then more frequent than yearly screening for those who are at increased risk. So people who inject drugs, youth, people seeking care for TB or bacterial sexually transmitted infections, and those prescribed pre-exposure prophylaxis. The interval for screening among these groups is not explicit. There's not been a recommendation for screening more than annually, but it is standard clinical practice in many clinics to do so. And really the main point of these recommendations is to routinely test. Do not only test based on perceived risk, so really integrate it into your systems. The impact of early diagnosis is significant, and even with the state of testing as it is now, significant numbers of people are identified far later in disease with more comorbidities associated with that. And people who do not even know that they have HIV account for 40% of new sexual transmissions of HIV. Once people do know their status, their risk behaviors tend to change. About 15% of people living with HIV in the U.S. do not know that they have HIV, and almost half of youth with HIV do not know that they have HIV. So, earlier testing leads to earlier diagnosis, linking people to care. The individual has a survival benefit, their partners have a benefit, and there's a transmission blocking step for the community, particularly if people living with HIV become undetectable in their viral load. So treatment as prevention is the concept that treating someone with HIV prevents that person from passing it on as long as their HIV viral load is below 200 copies per ml. And this was established by several formative studies. The PARTNERS study from the HIV Prevention Treatment Network, Prevention Trials Network, 052, so showed a relative reduction of 96% in HIV transmissions with early treatment of HIV in seropositive partners who were positive and had a negative partner. The PARTNER study, the Opposites Attract study, several studies looked at this as well and found 0 transmissions when the positive partner had an undetectable viral load. And there's really to date not been one phylogenetically linked transmission of HIV if the positive partner's viral load is undetectable. This has led to the U=U campaign, which means undetectable equals untransmissible. This has greatly reduced stigma for individuals living with HIV who do not have to live in fear that they're going to hurt their partners. It has led to changes in WHO and DHHS guidelines and basically has been a revolutionary movement that supports treatment for all people living with HIV as soon as diagnosis is made. So this is just to support that among those living with HIV/AIDS in the U.S., a large proportion are unaware that they're infected, a large proportion are not in care, and a certain percent, 20%, are in care but not suppressed. So in terms of the partner that has transmitted HIV, those are factors that make them more likely to transmit. You don't see a dark green bar here because those who are in care and virally suppressed do not transmit. In terms of the continuum of care, people living with diagnosed and undiagnosed HIV, there are over 1 million, as I mentioned, and we have a viral suppression rate of 56%. So there's clearly a lot of room for improvement in every single step along this continuum, but the first step is to diagnose. As we know, there's been great strides and great gains in the treatment of HIV over the past 3 decades, and you can see that the mortality from HIV has declined as the uptake of antiretroviral therapy has increased. So this has been really a victory story. Lifespan among those with HIV and those without HIV is now comparable, especially if people are treated with antiretrovirals. And most people with HIV tend to die of non-AIDS-related cases, non-AIDS-related causes, malignancies, mostly not related to HIV, co-infections, et cetera. So I want to shift right now to talking about pre-exposure prophylaxis and some of the benefits and barriers. Pre-exposure prophylaxis was established with formative trials that established the proof of concept that taking antiretrovirals, if you're not infected with HIV, can prevent you from getting HIV. And so there are now 2 medications approved for PrEP since in the 8 years since the first PrEP study was completed. There is TDF-FTC in a combination tablet, and there is TAF-FTC. TDF-FTC is approved for men and women. TAF-FTC is approved for men and transgender women, but does not have the approval for cisgender women, largely because the trials that established its efficacy did not significantly include women. But taken correctly, this can be really greater than 95% effective in preventing HIV transmission. But the first step in prescribing it is identifying people who are at risk for HIV infection, which really requires taking a thoughtful, non-judgmental, open-ended, open-minded sexual history and substance use history. It's important to note that PrEP is a program. It's not necessarily just a drug. It does not prevent other STIs, and it should be part of a comprehensive approach that's going to emphasize frequent screening of sexually transmitted infections regardless of symptoms, and education about safer sex practices, including consistent condom use, which is the best way to prevent other bacterial STIs. So when should you consider PrEP? If someone has had a recent sexually transmitted infection diagnosis or requests testing for sexually transmitted infections, reports that they have inconsistent or infrequent use of condoms, has recently had a situation where they've had to take post-exposure prophylaxis for an HIV exposure, indicating that they might be at elevated ongoing risk. If someone asks you for HIV testing, that may be a proxy for some of these other things. Has a partner who's positive, has multiple partners, or polyamory or non-monogamous relationships, sexual activity in an area of high prevalence or a network of high prevalence, has traded sex for goods or for money, the use of drugs, particularly in relation to sexual activity. All of these things are times when you should consider initiating. And these are basically CDC recommended risk behavior assessments for different categories of people. So the top is an assessment for men who have sex with men, and the middle is the assessment for heterosexual men and women, and the bottom is a risk behavior assessment for people who inject drugs. So that's a helpful tool. And then if someone has had a bacterial STI in the last 6 months, that is someone who should have PrEP considered for them. This is CDC and Preventative Health Services guidelines on prescribing PrEP and how best to do it. So the baseline testing does need to include a 4th-generation antigen antibody HIV test, which has a window period of about 10 days after acute infection to pick up HIV, and to screen and treat for any sexually transmitted infections, for hepatitis C, for sure for hepatitis B. It's extremely important to know whether someone has hepatitis B because both currently approved medicines for PrEP can fatally flare hepatitis B if suddenly discontinued. So if someone is testing negative for Hep B, they should be vaccinated. If they're positive, that needs to be a different treatment discussion. Creatinine clearance should be normal. People should have a pregnancy test to make sure that they're not pregnant. And you should not prescribe more than a 90-day supply. You do need to counsel on parallel risk reduction, and you do need to monitor closely HIV testing, risk assessment, adherence counseling, and sexually transmitted infection screens. The barriers to PrEP are multiple. Some of it is lack of awareness among providers. Some of it is lack of awareness among patients, low perception of their own risk. And then, there are individual costs. There are costs to payers. There's insurance lack, poverty, lack of access. Stigma is real, and stigma can kill. And stigma with PrEP is basically fear of being seen as taking something that confirms your promiscuity, or even might make people think you have HIV. Why are you taking these antiretrovirals if you don't have HIV? Sort of thinking. Prescribers may attribute stigma by having concerns that prescribing this may increase STIs or increase risk behaviors. Hepatitis B infection can be a barrier to PrEP. Adherence is an issue for healthy people who don't feel sick. Taking a pill that contains 2 antiretrovirals is a big step for a lot of people. And side effects do exist and can complicate treatment. And then there's mistrust of the system, structural barriers such as racism and incarceration as well. The PrEP of the future is going to include modalities that do not require daily adherence. So a recent game changer was the HPTN 083 study, which confirmed superiority and efficacy of an injectable cabotegravir PrEP formulation. So that was injected every 8 weeks and had fewer HIV seroconversions than a group that took Truvada daily. It should be noted that this was largely attributable to imperfect adherence in the Truvada group. An injectable means you have slow releasing concentrations of drug that protect you without you needing to do anything but return for your shot. There is a Merck product, Islatravir, that is being studied and has good pharmacokinetic protective levels for up to a year, and a pill formulation that could be taken once a month. Obviously, we need to have TAF-FTC on the market for women and available to women. Microbicides are coming up. Raltegravir plus 3TC is going to be studied. So there's lots on the horizon, and looking out for the results of the HPTN 084 study, which basically is going to recapitulate the long-acting cabotegravir versus Truvada, but in women in Africa, will be key. So shifting gears a little bit to antiretrovirals, I wanted to talk a bit about guidelines and new and emerging therapies. So the indications for choosing a new regimen for HIV is obviously if someone has just been diagnosed and is treatment naive, if someone needs to be switched for either treatment failure due to resistance or adherence concerns, side effects, any sort of toxicities, people who are suppressed, but there's concern that they might have poor durability and might have viral emergence, and emerging availability of drugs that have higher potency, higher resistance barriers, et cetera. If someone gets put on a new medicine that does have a drug-drug interaction with a component of their regimen, that's a reason for a switch. If someone acquires a new comorbidity that needs its own treatment, that's a reason for a switch. And you consider many factors in constructing a regimen, and it should be infinitely individualized according to your individual patient's unique circumstance and needs, but these are all the things that you can take into account. So the Department of Health and Human Services has updated recommendations for the initiation of ART from December 2019, and it's a Class A1 recommendation that all persons with HIV be on antiretroviral therapy, both to reduce their own morbidity and mortality and to reduce the transmission of HIV to others. This should be initiated as soon as possible in order to increase uptake, increase linkage to care, decrease the amount of time people spend not suppressed. And when you're initiating it, you have to discuss with patients the benefits and talk about strategies that might work for them to optimize their engagement in their care and their adherence to these medicines. So ART must be given to all with HIV, but for some the urgency is increased. And these segments are people who are pregnant or have a high potential to become pregnant because there's concern about them passing HIV to their child. Those with AIDS-defining conditions, malignancies, dementia, et cetera. Those with acute opportunistic infections, with a few caveats that require HIV initiation to lag behind opportunistic infection treatment initiation. People whose kidneys have started to fail from HIV, that can be reversed, at least in part, with the initiation of therapy. Those who are in acute infection, you want to get them started particularly right away to decrease their size of their reservoir, and those with hepatitis B or C. So there's high market complexity now as compared to the days in which we only had AZT. We have 8 different classes of drugs. We have more than 40 products. We have many different new classes coming on the market. This is a slide about what to start. So these are recommended initial regimens for most people with HIV. And the basis for recommending them was durable efficacy to suppress viral load, pretty well tolerable, low toxicity and ease of use, which often implies a single tablet. So first line would be an integrase plus 2 NRTIs. So Biktarvy TAF-FTC is a co-formulated single tablet regimen that is recommended. Dolutegravir, abacavir 3TC, is also a single tablet regimen that is first line if the HLA-B5701 test is negative. That is a test for abacavir hypersensitivity, which can be fatal. So if that test is positive, you would not start any sort of abacavir-containing regimen. There's also the option of doing a freestanding integrase inhibitor plus 2 NRTIs, and then an integrase inhibitor plus 1 NRTI, such as dolutegravir 3TC, that should say 3TC or FTC, except for individuals whose viral load is greater than 500,000 copies because of inadequate information on how they do with this two-drug therapy. So, if you have certain clinical situations, you might consider alternative regimens, and these are the regimens that you could consider depending on the particular clinical situation. But overall, based on characteristics of a patient prior to starting ART, if you had a CD4 count less than 200 cells per cubic millimeter, you would not use rilpivirine-based regimens. You would not use boosted PI or plus raltegravir, because those with low pretreatment CD4 counts do have a higher rate of virologic failure in that circumstance. Likewise, if your baseline RNA viral load is greater than 100,000 copies, you would stay away from selected regimens, including rilpivirine-based ones, abacavir 3TC with either efavirenz or boosted atazanavir, or boosted darunavir plus raltegravir, and that expands to dolutegravir 3TC is also one you would not use if your viral load is even above 500,000 copies. There's just limited data on how patients with those high viral loads would do on this dual therapy regimen, as mentioned. We discussed the HLA-B5701 being a contraindication to abacavir-containing regimens. And, do you have to wait for a genotype to start ART? You do not have to wait for a genotype to start ART, and in fact, you should not, because there's a recommendation for soonest possible initiation. And what that means is you should choose a regimen that's going to have a high barrier to resistance to start out with, and against which there's a low prevalence of transmitted resistance. So transmitted resistance to Biktarvy, dolutegravir, darunavir is rare, and these drugs have very high resistance barriers, so these are regimens to consider. Also, you want to stay away from an abacavir-containing regimen initially because the B5701 results often are not available immediately. What I wanted to stress here is that people living with HIV, the majority of them are over 50 years old now. So it's important to note that not only those who already have HIV, but over 6,000 of the new infections occur in those greater than 50 years of age. And because HIV is often not suspected in those over 50 years of age, they are actually more likely to be at a late and advanced stage of HIV when they come to medical attention, when they're diagnosed. They can experience accelerated and accentuated aging due to the inflammatory effects of HIV on their immune system and their body, and they have an increased risk of side effects with age, as anyone in any population does. As people age, they're on more medicines, so there's a concern for more drug-drug interactions. There's cognitive decline, which has its own impact on the ability to adhere to daily meds in a fastidious way. And there can be stigma, isolation, a lack of social support that significantly adversely affect the ability to remain on ART. There's a very sensible approach modified from a geriatric approach that was pioneered by Miley Karis, which basically says that there's there's going to be comorbidities in people greater than 50 years of age. You should focus on treating those that are modifiable, that relate to someone's ability to move and to think, that are going to have high complexity, and that matter most to the patients. So there's not necessarily a need to put someone on 18 medicines for every comorbidity they have. There can be a prioritization scheme with the well-being of the patient at the forefront of your mind. It's important to note that multimorbidity, which is defined as having 2 or more comorbidities, does increase with age when people have HIV and when people don't have HIV. But at least 22% of people living with HIV have more than 2 comorbidities, according to the large NA Accord cohort data set. So I want to shift gears to talking about a segment of the population that also is disproportionately affected by HIV, and that's transgender individuals. So a 2016 survey from the Williams Institute found that 0.6% of U.S. adults identify as transgender. They have a almost 20% prevalence of HIV worldwide, partially due to social, cultural, and structural barriers that impact their ability to engage with care effectively. There can be lower viral suppression, increased morbidity due to all of these overlapping factors that conspire to keep them out of care, as well as adverse experiences when actually engaging with care. Many have challenges remaining on therapy continuously when they do have HIV, and remaining on PrEP when they do not have HIV. And approximately half of transgender people use gender-affirming hormone therapy, which can have some interactions with antiretroviral therapy. Moving on to other sets of guidelines. So the International Antiviral Society guidelines also list alphabetically Biktarvy FTC as a first-line treatment, dolutegravir bacavir 3TC, and dolutegravir plus TAF FTC, all as first-line regimens. So that you can see the emphasis on an integrase-based treatment. Shifting gears to new and emerging therapies. So several agents have been approved in the last 2 years. I just wanted to highlight the medicines that are single tablet regimens, so they're co-formulated standalone single tablet regimens. And that includes Biktarvy, that includes Simfy of both doses, that includes Delstrigo containing Doravirine, Simtuza, which is a PI-based regimen with a pharmacologic booster, and actually dolutegravir 3TC, a standalone fixed-dose combination that does not require additional ART to keep people virologically suppressed. It's important to note that pill size can be a huge barrier for some people. Pill aversion and difficulty swallowing can definitely adversely impact someone's success on ART. Some of the smaller pill sizes here include Odefsey, Biktarvy, Delstrigo, but it's something to keep in mind that's quite meaningful and important to patients. Just to speak briefly about Biktarvy FTC TAF with the brand name Biktarvy. So this is containing a highly potent integrase strand transfer inhibitor. The trough concentrations that are established with clinical use are 20-fold higher than that required to suppress HIV. It is once daily. It doesn't require boosting, which can have drug-drug interactions, and it's been found to be non-inferior to dolutegravir containing regimens. And it can be active against many integrase strand transfer inhibitor resistant variants because it has quite a high affinity and a long dissociation constant. So it's got this high barrier to resistance that's an advantage. It does have metabolism through the CYP pathways in the liver, and so there can be some drug-drug interactions that are important to note. Moving on to Doravirine, this is a new non-nucleoside reverse transcriptase inhibitor which is on the market both as a single agent to add to other components of a complete regimen, or as a fixed-dose combination with TDF and FTC. So co-formulated with TDF FTC rather than TAF FTC is worth noting. It can be taken once daily with or without food, and it's treated for use in the antiretroviral naive or as a switch regimen for those who are stably suppressed, found to have equivalent efficacy to boosted PI plus 2 NRTIs in the Drive Ahead and Drive Forward trial. The Drive Ahead compared it to efavirenz-based regimens. There were less neuropsychiatric adverse effects than the efavirenz-based regimens and better lipid profiles than PI-based regimens. And then Drive Shift was their switch study, which showed that people who were virologically suppressed switched to this complete regimen of Doravirine, TDF, FTC did maintain their suppression with a high degree of durability and efficacy. Ibalizumab is of note because it's the first monoclonal antibody against HIV approved, and it blocks HIV entry into a cell by binding the CD4 receptor and inhibiting it from morphing itself and making conformational changes that enable HIV to enter the cell. It has orphan drug FDA approval for those with multi-class resistant HIV, and it's going to be active, unlike Maraviroc, which is active only against a virus that uses CCR5 as a co-receptor to enter the cell. It's active against both CCR5 and CCR4 tropic virus. It does have a long half-life. It's an IV infusion, which has its own pragmatic clinical challenges, and you administer it every 2 weeks after an initial load. But for people who are highly treatment experienced with few options, it can be a component of a successful regimen. Dolutegravir plus 3TC, as mentioned before, it is a standalone dual therapy regimen for people who have treatment-naive HIV, and can be a good regimen if you want a nucleoside-sparing regimen in people who have toxicities that make nucleosides problematic. So, also studied as a switch regimen. People maintain 97% virologic suppression at 48 weeks. This would not be an appropriate regimen for patients living with hepatitis B because 3TC is an ineffective and inappropriate option for treatment of hepatitis B. You need tenofovir, TAF, etc. Lower cost from two-drug regimens, lower cumulative lifetime drug exposures and toxicity are other considerations. Fostemsavir is the most recently approved antiretroviral. It was approved 2 months ago, July 2020. It's a first-in-class HIV attachment inhibitor. And it is a prodrug which gets hydrolyzed to its active form, and the active form of the drug binds to the envelope protein GP120 and blocks its conformational change and doesn't allow HIV to enter the cell. It should have full activity against resistant HIV strains. The approval is, again, for people with heavily treatment-experienced HIV and multi-class resistance. It is a BID drug. It should be taken with food, but basically, it helped people with multi-class resistance maintain a significantly greater decline in HIV viral load, and 60% on this regimen plus an optimized background regimen had undetectable viral loads at the end of treatment. The second study listed here is a phase 2B study comparing Fostemsavir, TDF, and raltegravir in highly treatment-experienced people living with HIV who have failure on other ART regimens and showed favorable efficacy and safety at 24 weeks. And these are other new drugs, basically new co-formulations that enable lower pill burden. It's important to note that the drugs coming up in the pipeline on the horizon use many different mechanisms of action, and you can review those all here. But the new ART on the horizon really focuses on long-acting formulations. Long-acting cabotegravir and rilpivirine are approved for the treatment of HIV in Canada as Cabenuva. Islatravir is a highly potent NRTTI, as mentioned, extremely long intracellular half-life, and is being studied with Doravirine as a dual therapy regimen, and lenacapavir, a capsid inhibitor that's highly potent, high resistance barrier, has potential applications for both PrEP and for treatment. So the real takeaways are that HIV is still prevalent in the U.S. New HIV infections are continuing to occur, even rising in some groups. Young men who have sex with men of color are disproportionately affected and bear an unacceptable burden of HIV. Guidelines are really emphasizing that all people with HIV should start ART as soon as possible, regardless of their counts or their viral load. And there's an emphasis in the guidelines on treatment regimens that include an integrase inhibitor and a focus on simplicity, tolerability, low toxicity, efficacy. There's an emphasis on duotherapy, new versions of familiar agents to improve pill burden, new classes of drugs, and the new agents likely to be approved in the next year or so include long-acting formulations of ART. So thank you very much for your attention and for listening. I'm going to turn it over to Cindy, who will talk about specialty pharmacy considerations. Thank you.
Thank you, Dr. Weld, for that introduction. I'd like to talk to you today about the role of specialty pharmacy in HIV care. A lot of times as pharmacists, when we look at national HIV goals or even the goals for the United Nations related to HIV, we feel that that actually pertains to physicians. And what I want to really call out to you today as pharmacists is that you have a critical piece of this puzzle that we need your help with, specifically specialty pharmacy. And so to look at that a little more broadly, here in the United States, our goals really are to end the HIV epidemic by 2030, which is only 10 years away. What we're looking at is a really big focus on prevention. So as you heard, we were talking about PrEP and different opportunities for prescribing medications to patients to prevent HIV infection. And if done well, what we're looking at is averting 250,000 new HIV infections in the United States. That's an amazing opportunity for us and one that we need to be a part of. The Center for Disease Control has really focused on certain geographic areas that have high rates of HIV, and the majority of that is here in the South, where I am coming to you today from Dallas, Texas. We are one of the counties that is a CDC target because we do have greater than 50% of all new HIV diagnoses occurring in a few counties throughout the United States. What that looks like across the nation is, unfortunately, 52% of all new HIV infections are occurring in the South. I am originally from North Carolina, trained in Georgia and in Florida, and now work here in Texas. And I'm very sad to report that Texas actually ranks second among new HIV diagnoses, outpacing traditional sites like New York and California, where they have wide-scale efforts towards effective treatment and prevention of HIV. So for those of you that are working in the specialty pharmacies, if you're looking for a place, the South is definitely ripe for the harvest. We need help and would encourage you to look at your services for the patients that are living in the South. As Dr. Weld very eloquently outlined, the steps towards reducing new HIV infections are really crucial to reducing the overall disease burden for HIV care. And that really falls into two different groups of people. Those who are at risk of HIV, and so that would be your risk reduction counseling and PrEP services, as well as those who are HIV positive and who are living with HIV. For those patients, we want to make sure that they're linked into medical care, that they're seeing their doctors, they're getting their labs, they're refilling their prescriptions, because in doing that, they'll be able to achieve that undetectable HIV viral load that's critical to their own health, but also critical to reducing new infections. I've been in HIV care now for 21 years, so it's been just amazing to me to see the changes that have occurred from an absolute death sentence in the early 1980s to this is really a chronic medical condition that is quite treatable. And as Dr. Weld said, for patients who are diagnosed before their CD4 count declines and are started on antiretroviral therapy, their life expectancy is no different than somebody who's HIV negative. So that means that I have the potential to diagnose somebody with HIV in their 20s and then live well into their 90s. So that's a lifetime of medical care that they're going to need a lot of assistance with from pharmacy. However, that reduced acuity of HIV care and turning it into a chronic medical condition means that a number of our patients are only scheduled for follow-ups with their providers maybe every 3 or even every 6 months. And as you well know, a lot can happen to a patient in 6 months. So that's led to gaps in between those medical visits where I think pharmacists and specialty pharmacies in particular are uniquely trained to fill because we interact with that patient every month when they come to get their refill. So I want to walk through, the two groups of patients in a little bit more detail and kind of talk about this status continuum. It always starts with an HIV test. You're either positive or negative. But at the bottom, that maintenance and ongoing support is so critical. And as I said, if a patient is only interacting with their doctor twice a year, that maintenance and support really has to come from somewhere else. And that's where I think pharmacy plays a vital role. For our HIV positive patients, we want them on treatment. We want them retained in care. We want them to have that HIV viral load be suppressed, both for themselves as well as for prevention of transmission to their partners. For those who are negative, we have a lot of opportunities there. It's a combination approach to prevention, including using medications that pharmacists are well versed at being able to prescribe and dispense and help patients with adherence. That continuing partnership is going to be really important to actually help that patient reduce the likelihood that they're going to require HIV and that they're going to keep coming back for testing to make sure that they remain HIV negative. So specifically talking about prevention of HIV with those who are already HIV positive, we talked about U equals U and what an amazing campaign that has been, so successful for so many of my patients, feeling so empowered that if they treat themselves and they become undetectable, that they will not give HIV to someone else. This moved our guidelines to, rather than doing a CD4 count-based decision on whether or not we start treatment, that we want to start treatment regardless of CD4 count. Well, since the last time that we did this lecture, what's also happened is something called Rapid Start. The rationale for Rapid Start is that starting HIV medications as soon as possible is important because so many of our patients become lost to care between the time that HIV is diagnosed and the time that they receive their first prescription from a provider. Now, why is that? A lot of times, if you think about it, what if you were diagnosed with diabetes? And wherever you were diagnosed, a hospital, a clinic setting, wherever, they told you, okay, well, we're going to wait until things get bad, and then we'll bring you back, and we'll be able to start you on medicines at that time. The patient really perceives that as a mixed message of, well, maybe I wasn't that sick, and I don't feel bad, so maybe I don't need anything. And that's really been a big issue for us. It was definitely an issue in Dallas where we at times in our clinic had, from the time we were notified by the health department that somebody was HIV positive until they actually got an appointment with one of our providers was 6 weeks. And so that was really difficult for a lot of our patients. However, if you switch that around and the day that that person finds out that they're HIV positive, you're taking advantage of that patient momentum, the interest, you're matching the urgency that this is important. This is an infection that we need to treat to give you the best outcomes possible. It enhances that linkage to care and engagement in care because it's also creating trust for that patient. You're addressing their anxieties about a new HIV diagnosis. You're addressing some of the mental health issues that come along with that, possibly even some of the psychosocial needs such as housing or substance abuse treatment that really led to them becoming infected. Reducing the time in which people who are newly diagnosed with HIV does, as we said, improve the time to virologic suppression, reducing the amount of time where patients are able to transmit, and potentially reducing new infections across the United States. Also, I would like to point out for those who have acute HIV infection, immediate initiation of ART may actually limit the HIV viral reservoir and preserve the immune system for those patients so that they never do progress to an AIDS diagnosis. Now, you may say, well, that's great for places that have lots of money and all these resources, but I would tell you that rapid ART initiation is supported by randomized clinical trials in both resource-limited settings as well as resource-rich settings, both inside the United States and throughout the whole world. This led to the development of guidelines in 2017 by the World Health Organization that defined rapid initiation of ART as within 7 days of HIV diagnosis, with further strong recommendations that ART should be started on the same day as an HIV diagnosis, based on that patient's ability and willingness to start. U.S. guidelines have followed suit, saying that starting ART at diagnosis is appropriate for nearly all patients. Well, looking at this a little bit further, what that means is that both U=U and Rapid Start have pushed providers into needing both immediate access to ART as well as ongoing support to help patients achieve and maintain an undetectable HIV viral load. Specialty pharmacies are uniquely equipped to meet this need because many of you can work with patients, insurance companies, funding sources, and help patients, no matter what their medication funding looks like, to actually receive that bottle of medicine in their hand on the day of their diagnosis. For those patients who have ongoing prescription fulfillment issues, specialty pharmacies don't usually run out of HIV meds versus a regular retail pharmacy. That might be something that they don't routinely stock, so the patient has to notify them to special order it for them. That really would not work in a Rapid Start scenario. All of our specialty pharmacies have outstanding adherence programs that can really reach out to that patient and provide that ongoing connection to a human being that they can talk to on a monthly basis about their needs for adherence. While a lot of retail pharmacies do offer automated refills through like a text message system or something of that nature, it's not the same as talking to a pharmacist who has knowledge in HIV care. Also, I would like to point out that a lot of specialty pharmacies support our AIDS drugs assistance programs throughout the United States. Specifically for Texas, that's been a really important thing to have some of our specialty pharmacies help, because the ordering process for the state ADAP program can be a bit cumbersome for patients, and specialty pharmacies seem to take over that and make it just a seamless process for our patients. So many HIV medications are expensive, and therefore they get tiered into different categories by insurance companies that sometimes make co-payments very difficult for patients to bear financially. There's a myriad of financial assistance programs through pharmaceutical company copay cards, as well as actual patient assistance programs for uninsured patients that specialty pharmacists are able to help patients. And I think just the key point also is always having access to somebody who can help with administration questions, drug interaction questions, including things the doctors may not know the patient is taking, such as over-the-counter products or herbal and nutritional supplements. So in speaking about the services that you offer, what specific HIV medications should you be focusing on? So the timeline for FDA approval of HIV meds from 1987 to today has seen many products come across, as Dr. Weld spoke of. Looking at our guidelines, in 2019, what we see is that there are several medications that have A1 level recommendations for our patients to use. Many of those are single tablet regimens. For example, pairing an integrase inhibitor with 2 nucleoside reverse transcriptase inhibitors are available in single tablet, 1 pill, once daily regimens, such as Biktarvy, which contains bictegravir, emtricitabine, and tenofovir alafenamide fumarate, as well as Triumag, which contains dolutegravir, abacavir, and lamivudine. As Dr. Weld pointed out, dolutegravir paired with lamivudine is also an option in a single tablet regimen that's available for patients under certain clinical situations. There's also a protease inhibitor that has a boosting agent with it, as well as 2 nucleoside reverse transcriptase inhibitors in a 1 pill once daily product called Simtuza. It has darunavir, cobicistat, emtricitabine, and tenofovir alafenamide. Well, in looking at these single tablet regimens, what stands out from some of the talk that Dr. Weld spoke of is that, for example, Triumag can't be used in a blind rapid start scenario where I have no lab values. Dovato is not recommended either in that scenario because I don't have labs to know if that patient has hepatitis B or to know what their HIV viral load is. So a lot of single tablet regimen use now in rapid start programs is either with a bictegravir-based regimen or a darunavir-based regimen. However, that's our new patient, our brand new patient that's starting out. What about all of our patients who are already HIV positive, especially the growing geriatric population that Dr. Wells spoke of? Many of our medications are actually now generically available. All but one FDA-approved nucleoside reverse transcriptase inhibitor is generically available. And pairing that with dolutegravir with two of our nucleoside reverse transcriptase inhibitors that are available generically is still an A1 level recommendation. So especially for your patients that are starting out who do have some financial barriers, there may be some alternatives that you can work with the prescriber and the patient's insurance company to determine for that patient. Raltegravir is also available with generically available nucleosides as separate pills as a B1 recommendation. The main reason for that being that raltegravir is a twice-daily regimen versus a once-daily product. There is a once-daily product that is available, but it's still 2 pills 1 time a day, and there is no single tablet regimen including raltegravir. But for a lot of patients, especially those, again, here in Texas, our state AIDS drugs assistance program has really taken advantage of generics to use that to expand our limited funds to make overall ART coverage more affordable and extend that throughout the state of Texas. There are also options, as Dr. Wells spoke of, with Doravirine to be incorporated into a single tablet regimen with nucleosides that do have generic availability, including those that would have improved adherence by doing so to put those in a single tablet regimen. So looking at reducing HIV transmission by prevention with those who are at risk, we'll talk more specifically about PrEP and what that looks like for specialty pharmacies. So comparing the two products that we have that are FDA approved for PrEP, Truvada, which is tenofovir disoproxil fumarate, compared with emtricitabine, and tenofovir alafenamide fumarate, which is paired with emtricitabine as Descovy. Both are 1 pill once a day. There are differences in the tenofovir component in how they're processed through the kidney and through the actual dosing recommendations. We have a more generous creatinine clearance allowance for the tenofovir alafenamide product to go down to a creatinine clearance of 30. We do have dosing available in adolescents. Clinical trials did include young adults ages 15 to 17 in the clinical trials for the products. So we do have a lot of information available on our young adolescent population, which, as Dr. Wells said, our age group of 13 to 24 years of age represents almost 1 out of every 4 new HIV infections across the United States. As for cost, tenofovir disoproxil fumarate paired with emtricitabine is now generically available. It is also the only product that is FDA approved for treatment of females or cisgender females. So that's an option for a lot of patients to have. Where we do see some opportunities to use tenofovir alafenamide in Descovy would be because of a patient that might have issues with kidney or bone toxicity, that might be an option for them. Again, looking at the South, I beg for your help. Any assistance that you can give to us would be so grateful. The South has the highest rates of HIV, and we have the lowest implementation rates of PrEP. I want to talk to you for a second about some opportunities for specialty pharmacies and how you can market your PrEP programs. Community awareness, I think, is the first step. You have to know that you're at risk for HIV to even seek out prevention options. So that's a way that specialty pharmacies, can really help to educate communities that they're working in to describe the services that your pharmacy can provide. I've had a lot of specialty pharmacies in the Dallas area have actually partnered with either a local HIV clinic or even our county health department to offer testing on site, especially for like fairs, such as like the HIV testing day. A lot of specialty pharmacies do offer HIV PrEP. And 2 that I'd like to speak about specifically for some of our populations are, we have one of our specialty pharmacies here in Dallas that has marketed their services to an OBGYN practice. Their goal is that no woman who is HIV positive will have a baby that is born that is HIV positive. And through wide-scale prevention with our HIV positive moms, we've been able to reduce HIV transmission in Dallas County to where we only had 2 live births last year who had HIV. So maybe not a traditional site that you would have thought about, for a specialty pharmacy service, but OBGYNs can actually be a great group of people to work with because they have such a high focus on preventing HIV transmission to the baby. The second group I would like to have your focus on is our transgender population. At the clinic that I work at, traditionally a significant number of our transgender care actually happened in our HIV clinic. And as we had a growing population of transgender people who were not HIV positive, the need arose to actually develop a specific standalone transgender clinic to be able to focus on the multidisciplinary needs that they have, such as psychosocial needs, as well as mental health and hormone-affirming therapies. From my perspective, I felt like that if you weren't going to address HIV, you weren't going to address all of their needs. If all you were going to do was just move them from the transgender clinic to the HIV clinic when they became positive, then there was no point in developing that clinic. PrEP was key to that patient population to keep them HIV negative, and it was a further affirming step to helping them engage in their medical care. Pharmacists can do this. I've been so impressed with the specialty pharmacies that I've worked with over the years because in many states, you can actually have a collaborative practice agreement where a pharmacist can actually help manage PrEP by performing HIV testing, either using point of care or a reference laboratory, managing those prescriptions, helping patients navigate pharmaceutical company copay cards to help with insurance, or even for the uninsured client, a patient assistance program, and in every step, fostering adherence and success. So the key takeaways that I see for specialty pharmacies is that you have tremendous opportunities to interact with HIV patients on a monthly basis, to educate them about the importance of lifelong adherence to HIV therapy, identify non-adherence, and help report that to prescribers to intervene prior to those semi-annual visits. Helping patients, again, through all the funding problems that can come with expensive medications, reviewing drug interactions, both for over-the-counter as well as prescription products, and at each step, assisting patients so that both for the HIV positive and for the HIV negative patient, you can help them to evaluate their risk, help them engage in PrEP services, and reduce new HIV infections. Together, we can eliminate over 250,000 HIV infections within the next decade. And with that, I'd like to take any questions that you have for myself or for Dr. Weld, and appreciate your time and attention to this program.
And our first question has come in for Dr. Weld to clarify the difference between using Truvada and Descovy for female patients and the way that Descovy was FDA approved.
Yeah, sure, Cindy. So Descovy is FDA approved for the prevention of HIV in adolescents and adults at risk for HIV. Through sexual transmission, with the exception of those individuals who are at risk for HIV through receptive vaginal intercourse. And this largely has to do with the fact that people at risk for HIV through receptive vaginal intercourse, for example, women were not included in the large trials that showed the efficacy of Descovy at preventing HIV. So those trials are forthcoming, but currently the label is for use in those at risk for HIV through other modes of transmission than receptive vaginal intercourse.
That's great. Our next question is for me. For Cindy, do you use a CPA to prescribe PrEP? Two answers. Number one, I only work in an HIV clinic, so all the patients that I see are already HIV infected. In the state of Texas, I do work under a collaborative practice agreement to take care of them for HIV as well as primary care needs such as diabetes or hypertension or anticoagulation. I do have a clinical specialist partner that works with our HIV negative populations doing PrEP, and it is through a collaborative practice agreement in the state of Texas. Thank you all for your participation. We really enjoyed putting this together for you, and I hope you learned something new today. And I'll let Dr. Weld say her thanks as well.
Yeah, just to echo those thanks. Thank you for your attention. Thanks for tuning in, and good luck in the future. Bye-bye.